Good morning, good afternoon, good evening. Welcome to today's workshop to address to inequity, challenging the global NTB agenda. Before we get started, I'd like to go over a few items so you know how to participate in today's event. Your microphone has been muted to avoid background noise, and we ask you to please keep your microphones off as well if you don't intervene to avoid background noise. We encourage you to turn your webcam on throughout the session if you're able to. Can we also please ask you to change your display name to your name and country? In today's session, you will have the opportunity to submit text questions and comments to today's presenters by typing your question into the chat. You can send questions via the chat at any time during the session. The moderators will collect them and address them after the speaker's presentation or in the allocated Q&A sections. You'll have also the opportunity to intervene also by submitting a request via the chat or by using the hand-raising Zoom function, and the moderators will record your request and inform you when you can intervene. You'll have the opportunity to provide feedback in the end of a session evaluation survey, which will appear directly in your browser when the meeting closes. So please complete the survey right after the workshop, as the link will only be available for a short period of time. You will receive a certificate based on your attendance and the completion of the evaluation survey. Also, please note that the event is being accredited by the European Board of Accreditation of Pneumology. Thus, you will be able to claim CME points for your attendance. Information on how to claim your CME credit will be shared after the workshop. The session is being recorded, and the recording will be available to the public a few days after the session. Finally, it is my pleasure to inform you that today's chair, Amrita Daftari from York University, and Jeremiah Shikovori from the Human Science Research Council. Over to you, chairs.
Thank you so much, Carolyn, for that introduction. Hello, everyone. Welcome to the Union 22 workshop on Address to Equity, Challenging the Global NTB Agenda. So as everyone settles into their seats or is perhaps ready to call it a night, I wanted to say a huge thanks to each of you for zooming in. I recognize many of you, and I'm so thrilled that you've joined, and I'm really excited to meet and connect with others over the next few hours. So we have a pretty exciting agenda planned ahead of us. Let me begin with some introductions and acknowledgements. I'm Amrita Daftari, a TB researcher based at the School of Global Health at York University in Canada, and a founding director of the Social Science and Health Innovations for TB Center, Shift TB. We're a growing global network of scholars, of advocates, learners, and organizations that are hoping to emphasize attention on the social dimensions of TB. It's a real honor for me to host this session together with Jeremiah, Nora, and Angela, and to have these wonderful speakers in our midst. I'll just take the opportunity to thank the Union for hosting us, and especially to Carolyn, Agnes, and Kara for assisting us today. Okay, so Jeremiah, can I kindly maybe ask you to introduce yourself, followed by Nora and Angela?
Thank you, Amrita. And thank you, Caroline. Good afternoon, good morning, and good evening, everyone. Well, it's a pleasure to join you in this session, and I would like to second the welcome that has been given by my co-chair, Amrita. I'm a sociologist based at the Human Sciences Research Council, and together with Amrita and Nora Angel, we co-founded Shift TB, which Amrita has already referred to. And I would do my work primarily on men and working from the Global South. And it's a pleasure to actually join this conversation on equity. And I look forward to exciting discussions. Over to you, Amrita.
Thank you. Nora, go ahead.
Hello, everybody. Welcome. And it's great to see so many people signing into this workshop. I look forward to some very interesting discussions. My name is Nora Engel. I am an associate professor at Global Health at Maastricht University, in the Netherlands. I have done research on how new technologies and interventions for tuberculosis care and control are being envisioned, designed, developed, and then implemented. And I'm particularly interested in how equity comes to matter in these innovation processes. So I look forward to the discussions today. Over to you, Angela.
Hi, it's lovely to see so many people. Thank you for taking the time to join us today. My name is Angela, and I've had the privilege of working with Amrita, Jeremiah, and Nora in the past couple of years, working on Shift TV and putting some names to faces today as I recognize some of these names that are in the room with us today. And I'm just really excited to kind of explore this idea of equity and TB a little more with all of you. Yeah, just getting to work with these three wonderful humans the past few years has really been a privilege. And yeah, now I'm kind of pivoted a little bit into more of the science world, but love to learn and from all these brilliant minds, and excited for the discussion here.
Thanks, Angela. Thank you so much. We're also very, very excited, as I mentioned, to have 5 brilliant panelists today who will be introduced more fully and rightfully right before they speak. But I'll ask if you can please just turn on your cameras. Thanks, Grania. I see you're here, and Ernesto. So there's Ernesto Jaramillo from the Global TB Program at the World Health Organization, Uzma Khan from IRD Global. We have Yulia Chorna, connected to several TB advocacy organizations in Europe, Grania Brigden at the Global Fund, and Shea Abimbola at the University of Sydney. So Shea has sent his regrets for not joining live, as it's near midnight in Australia. Now, the envisioned goal for today was really to center stage social and health equity in conversations about TB elimination. And I think most of us would very quickly agree with the age-old adage, TB is a social disease or a disease of social inequity. But we may just as quickly agree that day-to-day efforts to address the epidemic could be falling short of addressing these inequities or even engendering that social framing. So by no means is this a first attempt to address inequities in TB. That battle had begun long ago with established and aspiring leaders in the TB community, several of whom are on our panel and the audience today, and many who have been at it for decades to come. But by no means is this workshop going to also identify a solution today to fix this unimaginably complex problem. But what perhaps we can accomplish today is elevate the conversation, carve out a dedicated space to discuss, to address some of these inequities, tear them apart, hopefully for years to come, have some meaningful, inclusive, and actionable debate, and perhaps reflect on how we could prioritize social equity and health equity in the work that each of us do in TB. So with that in mind, we hope to firstly take some inventory of the systemic gaps that underlie inequities in TB. Second, brainstorm how funding, research, policies, and community actions could perhaps more explicitly attend to those gaps, the social and structural determinants of TB, really. And third, perhaps reimagine how such efforts that we're putting in can be done in ways that are at the outset, and by definition, community-centered, inclusive, and decolonizing. So harnessing the insight and experience of this esteemed panel and you, our esteemed audience, let's have a candid, critical dialogue on the current architecture of the TB response. Let's sort of take stock of what's been done to date to address inequities in TB and see if we can work together to move that agenda forward. Some quick housekeeping reminders, just borrowing on what Carolyn shared. This is a 2.5-hour session. We could wrap up earlier. Each presentation is about 12 minutes. Kindly type in your comments and questions into the Zoom chat as and when they come to you. We will pause to address them after each speaker and take up anything pending, as well as new questions for the panel in the discussion. Thanks in advance for staying on mute unless you're speaking. We welcome everyone to turn on their videos, and please feel free to raise your hand on Zoom during the Q&A and discussion. Jeremiah, Nora, Angela, all my panelists, have I missed anything? Okay, so with that in mind, it is my absolute pleasure to introduce our first speaker, Ernesto Jaramillo. Dr. Jaramillo is a Colombian medical doctor with a PhD in health education from the University of London. His portfolio spans just nothing short of tremendous, covering clinical, programmatic, and research issues in TB. For 16 years, until 2018, he has published extensively and supported countries in uptaking many innovative policies in drug-resistant TB. Since 2021, he served as lead for the ethics, equity, human rights, social protection, and disability sections of the Global TB Program. When I first met Ernesto, I was a student, just awed by his take on social issues in TB, and I'm so grateful today to have his social science insights begin the panel. Over to you, Ernesto.
Thank you very much, Amrita, and thank you for all participants for the interest to be with us. I want to recover some comments in the opening remarks of Amrita when she's saying, let's look for what are the gaps that we are having in the TB community when we want to address inequity. And I just realized that probably one of the gaps I want to highlight in this 10 minutes presentation is the discourse that could inform our thinking, but also our action in the response to TB. A response that is heavily monopolized by the biomedical components, the power of the medical discourse, the power of the medical tools at the expense of the other interventions that are equally, if not even more important, in the response to TB. So what I want to share with you then in these 10 minutes is what is in the WHO documents and policies that can help community sensitized around inequalities, inequities, and human rights to mount a response that goes beyond and can really provide a more comprehensive response. I declare I have no interest that can compete or conflict with my role in this symposium. And let me go straight away to the first obvious point. We all know people with TB everywhere are the most vulnerable people in any society, are the people that usually in any society nobody wants to be associated with. The prisoners, the migrants, the minorities, elders, children, people who are suffering from stigmatized conditions like mental health disorders or HIV, substance users, and put all this in a blender when you have a migrant who is an elder who has HIV, and then you get the whole picture even more complicated. So in this context, then what is the response that the world, the WHO should be supporting to address the grim reality of these human beings? Is it just to put pills, drugs, medicines in the mouth of people? Let me walk you then through a key document that was produced in 2017 as an updated version of one that was launched in 2010, which is the guidance on ethics, equity, human rights, that presents a collection of fundamental values and goals for a human rights-based approach to TB. And the first overarching goal that is presented in that guidance is that ending TB is a matter of social justice. It doesn't say that it's a matter of ensuring access to medicines only. It's a matter of focusing the fundamentals first, the rights and obligations of people, but also states, to ensure that human rights are protected and that interventions are based on sound ethics, and sees social justice as just ensuring a fair distribution of advantages and burden among people. And why this is important, I'm not going to go into all the detail. You can go to this document that is in the website, but the idea of ensuring that we have justice, social justice as a fundamental column in the response to TB implies as well to address the social determinants of the epidemic. Those are the determinants that are giving shape and direction to the epidemic. And there is a fact that I want to rescue from the Global TB report that has been released a couple of weeks ago. It's not only that poverty causes tuberculosis, it's that TB exacerbates existing poverty. And here we have hard data from patient cost surveys that have been conducted already in 27 countries. So then in this context, addressing the socioeconomic determinants of TB that are contributing to give direction and size to the epidemic is not an option, but it's an essential component of the whole response. There is an awful lot of suffering, as we know, and there is an ethical duty to address that suffering. And that implies to look at what are the mechanisms that can be offered to vulnerable population to handle that vulnerability, to be able to have decent and dignified lives, and not only to have the body clean of Mycobacterium bacilli. So no wonder why in the progressive NTB strategy launched in 2015, there is a pillar 2 that includes social protection, poverty alleviation, and actions on determinants of TB as an essential component, as important as the biomedical component, for which the universal health access is of course, it's essential, it's necessary, it's part of that human right to health that has to be protected. This statement, this position, this approach has been upheld by the heads of state that have signed off the political declaration of the United Nations General Assembly on tuberculosis in 2018. So I know here that all this discourse about addressing social determinants is just because there are a collection of passionate people. No, this is a political position of the heads of state, of all those who are part of the UN system. So it's more up to all of us to see how to support countries to ensure that this is properly implemented and can really address the social injustice that is feeding the TB epidemic. Here, I just want to refer to a couple of publications that are informing with hard evidence the rationale for using social protection as one powerful way, one, not the only, but one powerful way to address social determinants in order to reduce inequalities in tuberculosis. Modeling shown very clearly that if we focus on those SDGs, Sustainable Development Goals associated with poverty, there are very clear evidence of the impact they can make on incidence. Investment in social protection in this analysis shows clearly a correlation between the monies that member states put in social protection and the prevalence, incidence, and mortality of tuberculosis. It's a linear trend in the correlation between those investments and these three key indicators that can tell us how we are making progress in the response to TB. By social protection, it's important to be clear and referring to all those kind of schemes, allowances, services, commodities that are offered to people who are vulnerable in order to alleviate their poverty and to relieve the social exclusion they are exposed to in any society. Global TB report launched a couple of weeks ago show a grim reality. Although social protection has been part of the NTB strategy since 2015, the report of 2 weeks ago is showing how only 16 out of the 30 high TB burden countries are having a national policy on social protection for people with TB. Imagine if instead of saying this, I would be saying that only 16 of the 30 high TB burden countries are offering TB medication to people with TB. I still haven't seen yet a single tweet or a single statement showing the outrage in the TB community because of the absence of social protection in 14 of the high TB burden countries. That gives you an idea of the huge, huge challenge we have in front of us. WHO and the Department of Tuberculosis has a focus in the last couple of years to strengthen the position of social protection in order to address social determinants, in order to face TB as an epidemic of social injustice. And I want to refer to 3 key documents. One is the multi-sectorial accountability framework. It's not only about accountability, it's about going beyond the health sector to address the roots of the epidemic. The second one is the National Strategic Planning for TB. At the end of the day, countries don't do what the technical agencies like WHO recommend. Countries do what they get funded for. And the National Strategic Plan is the most powerful tool for securing the domestic funding and the international funding in the context of a disease that has got chronically underfunded as it compares to other diseases like HIV, for example. And then, last but not least, I want to refer to the guidance on social protection that is being finalized and will be launched in Q1 coming year, which is going to be the first ever guidance on to countries on how to address this, and is developing collaboration with the International Labour Organization, which is the agency of the UN system that is responsible for social protection. Next year, we are going to have this year we are having the planning of the next year United Nations high-level meeting on tuberculosis, which is going to be an opportunity not only to maintain this level of commitment, but going beyond and securing that, for example, these gaps in the commitment of countries to ensure that people with TB systematically are offered social protection as one of the key actions to reduce inequalities by addressing their vulnerabilities. I would like to stop here and thank you again to Enrita and all the organizers and for participants for their interest in this critical area. I want to also acknowledge the 3 colleagues who have contributed with some ideas and slides to this presentation. Thank you. Over to you.
Thank you, Ernesto. That was fabulous. A really nice broad overlay of what's happening globally and at the GTB. And you know, I'm curious. I have some questions, but let me see if others do. Anyone from the audience has a question for Ernesto? You can either type it into the chat box or raise your hand and ask it. Well, I was pretty impressed reading the latest global TB report and just seeing the diverse indicators, if I may say so, that seem to be represented in the report. You know, ideas around social protection, even sort of attribution of people affected by TB with regards to malnutrition and a couple of other social determinants. So that's certainly a step forward in the right direction. Ernesto, I'm curious, these are sort of global, oh, Grania, go ahead, please. Mm-hmm.
Sorry, I was typing my question into the chat box, but while others are thinking about their questions, I mean, Ernesto, I completely agree that the sort of NSP is a key document in sort of a country's response, and it'd be great to sort of get your thoughts and reflections on how that NSP can be more than just sort of looking at notifications, case finding, but really prioritize some of the human rights, social determinants, sort of all the things you've outlined, because I think sometimes it can stray into being more of a technical, sort of from us technical people, a technical document that just looks at some of those more specific indicators. And I think maybe what the new guidance from the WHO has that can help countries make a much more sort of broader NSP, thinking about some of these other areas that you've very rightly highlighted. Thank you.
Do you want me to answer now, Dr. Enrita?
Yes, please go ahead.
Yeah, no, thank you, Grania. This is critical. I would like to insist that countries don't do what is being recommended out of a paper in a top journal. They do what they get funded for. Right? And that's why securing the funding is the most critical element and has resulted in the total revamping of that guidance on how to develop a national strategic plan. For those who can go to this document, they can see how human rights for the first time is really featuring throughout, right? And a focus on social determinants that begins by, during the situation analysis, not only to focus on the epidemiological aspects of the epidemic. Oh, what is the treatment outcomes? What is the cure rate? How many gene expert machines are deployed? Is everybody having access to the data? Of course, that is important, but that should not be the only thing to do. So it begins by saying, okay, where is and how is the current services being offered to address those vulnerabilities through social protection mechanisms, and what are the mechanisms to secure the funding that quite often already exist, because virtually every country has some forms of social protection. The question is now how to secure the funding and the access to ensure that all those with TB are properly covered. So this new NSP is a pretty innovative approach compared to the previous version that was very much focused on the pillar 1 of the NTB strategy, which is basically the biomedical response. Building on that, we are now presenting a more comprehensive approach, but it's very much up to the whole TB community to take this NSP guidance, right, and make the best proper use of it, and not to use it to continue doing more of the same. The NSP is developed by the country and their partners, not by WHO, right? Civil society has to stand up and secure that the vulnerabilities are properly addressed and that human rights are protected. Over.
Thank you, Ernesto. Any other questions? I see there's a question, Ernesto, from the chat box on the around the table that you showed from Ramon de Patencia. So interested to see that the South African field on the table, I guess this is the table of social protections that you showed, Ernesto, has no color coding for South Africa. Could you elaborate on this? Did it go beyond the social grants for a few months?
We stick in the report to what the countries have reported to, right? So we know that in South Africa, there are quite innovative policies when it comes to social protection, but the question was very explicitly asking if there was a very tailored approach for TB that can secure that people with TB are considered systematically for this, right? I see another question, if I may, Rita, about how can people patient-centric approach be intersect with social protection strategy. I mean, the definition of people-centered approach is nothing different than ensuring that values, needs, preferences of the affected communities are taken into account. Well, and social protection is about addressing vulnerabilities, right? It's about addressing a very practical, concrete need. People with that are affected with TB are not only having their lungs affected, it's not the cough and the fever, it's how this disease affects the total social life of people. It's how it's affecting the productivity, the capacity to make some income, but also the social relation because of the stigma attached to it. So equipping people with the tools for them to handle these vulnerabilities is as important as providing the medicines for the body to be able to respond to the challenge of the mycobacteria. So that is very well justified. If you have a real people-centered approach for TB, then social protection cannot be an option, but a core element of the response.
Thanks, Ernesto. Thank you. So before we move to Uzma's talk, I just had a quick question to ask the audience. What does equity mean in your context? I'm curious, like we're all curious. We wanted to collect this inventory. You know, when you think about TB inequities, maybe that's a better way to think about it. What are the things that come to mind and what's relevant in your context? For example, is it around gender? Is it about social protections? Is it about a specific legal protection? If you could type that into the chat, that would be really helpful. Again, just for us to collect inventory to see what are some of the key issues that we should be thinking about when we talk about TB and inequities. So I'll put that question into the chat box as well for you to answer as we go through. And over to Jeremiah to introduce Uzma.
Hello again. Or coming from one great talk to expecting another brilliant one. It's my singular honor and pleasure to introduce someone I so look forward to meeting in person because of their self-evident passion for justice, reflected through their work and advocacy, a person who marries and combines and embodies multiple experiences and deploys that special occasion in highly effective ways to call out and act against injustice. Uzma Khan is a physician, a TB implementer, a researcher, an advocate for TB and integrated health practices, and fighter for justice and equality in all domains, not just in health. She's a TB survivor and has spent the last 12 years working in low and middle income countries, overseeing, implementing, and evaluating TB programs. Khan is based at the IRD Global. She's central co-I in the END TB clinical trials and a member of the regional Greenlight Committee for the WHO EMERALD region. Her interests are in implementation, science, health, equity, advocacy, and policy. Over to you, Uzma.
Thank you so much, Jeremiah. I'm really excited today to participate in this workshop, and thank you so much to the organizers, especially Amrita and colleagues. It's really exciting to talk about this, and as Amrita said, kind of tear apart some of the issues that we see in TB and in terms of how we discuss and how we challenge our, the narrative that exists. So I'm going to try and share my screen, just a second. So I hope everyone can see my screen. So I'm going to be talking to you about equity in TB and more from the lens of an implementer and some of the injustices that I have seen in my experience. And this is not to just make people uncomfortable, although I feel in TB we should feel uncomfortable, given the kind of area it is. But it is also to motivate people and organize as a TB community. And some of the points that Ernesto raised around how we need to make sure that countries are also, we support countries. I think that will only happen if TB community also organizes and addresses some of these issues, and which we don't see much. So I hope this will be a little more, not just an uncomfortable thing, it will be also kind of make people reflect and even share some of their own experiences. So going into, some background around what we already know in terms of the foundational issues that we see in TB that have led to some of the injustices. Now, we know that there has been, in programs that we work in, there is a conditioned mindset, a culture and entire economies that are, perpetuated through, these colonial practices in the past, from funding to evidence generation to policy making and service delivery. Okay. Inequitable partnerships that create power asymmetries, racist hierarchical divide. And certainly we see this on the ground in terms of colonial style tactics, which divide collaborators. And deploying agents of previous colonizers to continue to drive the TB disease control agenda in low middle income countries, and something that I will speak to later on in the presentation. So when we talk about equity in TB, I think it's important to look at external factors and threats. And certainly the current example is the climate crisis. And we saw in, the Pakistan floods cripple the health system, including TB services. And people with TB and their families were left to face dire consequences, including a burden of a lot of health outbreaks and certainly food insecurity, job insecurity, and other ongoing issues that continue right now. And it was really, disappointing to see, the lukewarm response of global allies, to this crisis. And when you would have expected to see a lot more outrage and, funding, pouring in during this crisis. So moving on to today's, going around some of the issues that in TB, we know that all aspects of TB care have colonial roots. And I think without talking about these issues, we're not going to be able to organize ourselves to create some solutions as well. So I'm going to go through each of these today. But before I talk about it, just a few words on autocolonialism. And now there are other words that describe this as well, but this is something that kind of I relate to, and maybe perhaps more based on my own experiences. And it will come into some of the aspects and examples that I talk about later on in the presentation. But I want to kind of, I couldn't find a proper definition, or, it's imperfect, but this is what I found. It's neocolonialism and a traditional colonialism, only that it's being done by citizens of a country on their fellow citizens. And in TB, this manifests through decades of dependence on external funding, fragmented local governance structures and political agendas, creating a system of discriminatory policies and practices that perpetuate a bilateral colonial mindset. Now, moving on to the topics that I would like to discuss, talking about external assistance. So in external assistance, the main problems are these power asymmetries between donors and recipients with externally determined priorities. And unfortunately, you see this relationship of a master and underling as poor countries fight the battle, to secure financing for TB. And there's an intense focus on innovation and cost effectiveness. And while that's important, it occurs without ensuring the achievements in service coverage are maintained. There's a lack of context, guidance from external experts from low TB burden countries in the global north that drive the agenda and certainly the funding stream. Now talking about policy making, and this is more from the lens of, again, the implementer, and talking about how country policies are made. So we know that in low middle income countries, the TB programs seek guidance and validation from the WHO, and this is driven by external financing. For example, the Global Fund money aligned with countries implementing WHO policies. And country TB strategic plans are guided by external stakeholders, funders, and global TB policymakers. In most cases, these are the same groups which provide the financing. And this prevents local input, context, and ownership. And while this is not something to say that it's happening across the board, but we see that in a lot of countries. Program monitoring. So this, I feel, is a case of micromanagement by external influencers, donors, and through these colonial agents. And I have seen, these setting up of unrealistic targets, which if they're unachieved, there are threats to pull out funding. And some of the influencers influence which areas receive funding and benefit M&E. And these scheduled and ad hoc monitoring exercises that create mistrust and leave programs feeling less empowered. And finally, TB program audits that are conducted by people who, without appropriate technical and research qualifications, that oftentimes justify cutting losses and leave entire programs destroyed and patients without care and stifle local, achievements. So moving on to TB research. Here, the same power asymmetries that I've been talking about kind of feed in, where this prevents knowledge production in the global south. Insufficient funding for research capacity building, institutions and researchers from the global north dominating the research agenda, including disproportionate monetary compensation for local researchers, and a lack of credit and representation of local authors in research publications, which is also gets these exorbitant costs in terms of that have to be covered for publication. And then international conferences being held in areas where, which restricts local representations due to visa restrictions and travel costs. And finally, a culture of data hugging. This is almost this territorialism, around data. And apart from the people who produce it or who provide it, I think there's a lack of transparency and accountability around this aspect. And some of these lead to harms of selective information sharing, which also lead to policy that we see. And when we talk about research mobilization and equitable access to local authors, and I think it's important that scientific journals apply an equitable lens. And here I'm sharing an example of an issue, but also providing a solution in terms of how we should try and advocate as a TB community. So recently, I co-authored a correspondence. Here we were reviewing evidence around standardized fluoroquinolone-based TB preventive therapy for exposed household concepts of MDR TB, and we're looking at the benefits and risks in terms of using standardized approaches in settings, especially those which have high fluoroquinolone resistance, based on current observation studies and the new trials that are happening. So we received a response, this is unpublished, but surprisingly was accepted by the journal. And the main argument that the authors had with our correspondence was that in low resource setting, it's not possible to take into account patients' drug resistance patterns and no perspective that the situation will change in the foreseeable future. And that public health policy should maximize the utilization of scarce resources for those who may benefit from it. Thus implicitly, stating and accepting that it's okay that a proportion of people will not have access to the most effective treatment strategy. Now, we decided to respond to this, and in summary, we said, as individuals who represent and advocate for equitable access to resources for our colleagues and patients in low and middle income countries, we can strongly disagree with the above arguments. We affirm that justifying an approach based on available resources would perpetuate inequities, othering of the plight of affected TB communities, and emboldening epistemic injustices in global public health. And the purpose of sharing this example is to say that, I think it's important for us to figure out our way of communicating some of the injustices and talking about them. It doesn't need to be in the same forums in all kinds of ways. I think scientific community needs to get a little uncomfortable and write things when they represent TB patients and providers as well, and figure out ways to advocate on behalf of them. TB technical assistance. So I'm going to talk about this, but just to say full disclosure, I have been providing TB technical assistance myself, and I think it's in a valuable area. It provides a lot of insights for people, especially when they're going in as well. But it makes me extremely uncomfortable because I see some of the injustices that I see, which I feel can be, kind of exacerbate and perpetuate some inequities. And there's some work that needs to be done there. And one of the reasons why I participate is because I want to kind of create those avenues of change. So on the left, you will see influencing factors in this table. So I've got some examples on the right. On the left, there are these, these influencing factors and environments that lead to this. And obviously, this is not an exhaustive list. It's more from the perspective of me in being in the field, whether it's as an implementer or as I've observed in, as a while participating in TB work. So global experts have power to influence guidelines, national strategies, and direct funding streams. And here we have seen examples of in recent times where there was, when bedaquiline was rolled out and became initially recommended, there was a fear of drug resistance and desire to protect the drug, which led to early policies that restricted its use in people with limited treatment options and often as a last resort. And then another example that I saw that is more of recent times is an external expert influenced local policy of a high TB burden country in favor of smear microscopy, a less sensitive tool for diagnostic, to be the primary diagnostic TB test, when a more sensitive method like a gene expert was available. And certainly, I'm sure that the same consultant would not advise the same for other high-income countries, and not definitely not his own. And going back to the concept of autocolonialism, so this is the global South self-sabotaging, this lone local voices and stifling local capacity. I think this there are a lot of examples in this, and this is where you see programs discriminating their own experts in the field and instead recruiting international consultants at exorbitant prices. I've seen this. I've certainly felt it as well. And then local organizations preferring external advisors to local homegrown thought leaders. And finally, a non-collaborative environment accompanied with condescending attitude and behavior. So here I've seen, and certainly more in my early years, when I was, I have seen some consultants openly criticize clinicians and programs who are working tirelessly, often with limited resources or training. And then global groups and networks that normalize use of inappropriate analogies. And in recent times, I saw this in a meeting where an external expert displayed, a burnt toast to exemplify the plight of a South Asian TB program, which was highly inappropriate. And I called him out on it, and a lot of people went to his defense. But I do think that it's important, even if that happens, it's important to raise voices in the face of any kind of practices that are inappropriate. Service delivery. So here I will talk about three things. One is related to, policy implementation gaps, and second is community engagement, and third would be, I will be talking about the implementers' role and how they are, unempowered. So in the policy implementation gaps, we often have guidelines recommend what should be done and not how it should be done. And for example, designing drug-resistant TB regimens in the absence of tools to establish eligibility based on global recommendations. And donor prioritized tools innovations without accounting for local context. So an example here is the uptake of the active case finding strategy. I think it's a very valuable strategy. It's really important, especially when you do, especially in the areas that I've worked in as well, and I've even participated in it to increase TB case detection. But when it happens without addressing other barriers and creating avenues for resources to address these, like cultural, socioeconomic, and gender-based, then this prevents scalability. There is an absence of community engagement with dearth of investment in community leadership that includes TB-affected households, and centralized implementation models that prevent access to services, which can lead to unfavorable treatment outcomes. And excluding such voices perpetuates distrust in affected communities and limits uptake of effective interventions and representation in research. And finally, not valuing roles of community health workers who are the backbone in terms of bridging the communication between facility, clinicians, programs, and the community. And this is generally undermined by these discriminatory policies, which inadequately compensate community health workers, can often consider them as volunteers. Implementers are unempowered because of these externally imposed and locally endorsed protocols and guidelines. And partly it's because they're conditioned to deliver care using standardized approaches, astutely following guidelines which are unlinked to local realities, and older conventional ways that hinder inclusion of newer approaches. And physicians are overburdened and poorly compensated. They experience burnout, and they're disincentivized to continue working in TB. And in the absence of the most basic resources, and which I've seen even like, routine blood labs, physicians are unable to make people-centered decisions and contribute. And while funders argue that, some of these resources should be available domestically, and ideally that should be the case, and I completely agree, but in reality, that is not the case. So turning a blind eye to something like this is just negligence. And so talking about dangers, here I want to talk about dangers of like selective advocacy. And I see the silos in TB, which is why I want to advocate for more organized movements, collaborators globally and locally as well. Is because there are these silos that exist right now. So for example, advocating for active case finding for TB without using old methods, just to maximize limited or resources, an example of which I provided earlier as well, and not for creating equitable access to newer, better diagnostics, and then advocating for TB treatment equity and not for equitable solutions to monitor treatment response, advocating for preventive therapy without equitable access to reliable methods to exclude TB disease, and scientists' inability. They are the backbone in terms of producing evidence, but there seems to be an inability to effectively communicate with those with affected communities and appropriately disseminate their findings in order to make them feel empowered and be a part of the TB community. And my final thoughts, I've taken too much time, is to demand restructuring of a system that benefits a few, I think it's important to demand representation based on mutual respect and dignity, and acknowledge that change brings conflict and discomfort, and that beneficiaries in powerful positions may be concerned about systemic change. Support humility and constructive collaboration instead of unhealthy competition, facilitate researchers to effectively meet advocacy, and demand that external assistance for health aligns when responds to the needs of local health systems, and enables rather than undermines sustainable coverage of services essential to achieve universal health coverage. And I'll leave you with this quote. Hopefully this is a little more uplifting than all my presentation, and I'm happy to take any feedback or questions. Thank you so much for listening.
Thank you so much, Azman. Very, very incisive talk indeed, and inspiring. We cannot shift the ground without making ourselves uncomfortable indeed. I'm going to ask our audience to pose questions for you. As before, could you could type in the chat box. We'll give it a minute, or you could raise your hand. Okay, while we wait for that, Usman, I'm going to be selective, and you raised your concerns about being selective, but I'm just gonna ask you to sort of look within countries, and I'm thinking more about local contexts. What can be done to bring power back to communities?
I think it's going to be it's a good question. It's also a difficult question. And a part of it is that, I think where I talk about this, because these are all structural systemic issues, they're not things that there's years of stuff that is, that's going on, and these power asymmetries that exist, whether it's globally or even locally. So I think it's important to create a momentum and organize. I mean, this workshop is part of it, and I think communities that actually have even a little bit of power in the global, movement, and how they work in TB, I think they need to advocate, and without getting uncomfortable out of their own, and more aligned to who they are. And certainly, I believe that sometimes I don't feel like I want to do a lot of advocacy in things that I don't feel it doesn't really reflect on who I am. So I feel like there are ways to do that, but community mobilization is almost like doing justice to the voices and the people that we serve and we work with. And I think there's a lot of work that needs to be done in terms of organizing people to work together, different people, and making people. And that's why I feel like there are silos that I've seen that exist because of areas of expertise. For example, my interest is in drug-resistant TB, but so that's why I have to consciously make sure that I am looking at TB as a holistic approach and talking about communities and integrated practices. And so it's important to shift that.
Indeed, thank you, Usman. Do I see a question from Shifa? The question is, thanks for the very insightful talk. What do you see as the role of the private sector in decolonization of TB care? And we often see the lack of effective public-private partnerships that exacerbate inequity in TB care in high-burden countries. For example, better funding and resources in the private sector.
That's a good question. And I feel like it's important to realize that all of this shift will happen when we have to look at context perspective. There's a lot of work in TB that we're unable to implement on the ground, especially when we talk about intersecting sectors as well, is because of these standardized approaches. Okay. And I think there are a lot of, so getting out of making strategies. When we talk about innovation, it has to be a bottom-up approach. It has to be look from the context point of view. When you impose strategies that as is without contextualizing local settings, I think what happens is only those with power on the ground, whether it's the private sector or those with money or those with resources or connections or whatever, are able to then deliver. And so it's easy to have that kind of thing. Public sectors are generally underfunded and they don't have the health infrastructure. So if you don't figure out like how to make TB more horizontal and advocate for and figure out resources and funders make funders, recognize that, it's important to actually look at context specific strategies. It will not allow public sector to be an active participant as we see right now.
We'll just take one more question, and if there are other additional questions, we'll take them at the end of the presentation. So there is another question for you, Uzma. So, and let's just say that part of what's missing in social protection is the role of civil society standing up to ask for it to move towards it. But we have seen locally, especially during COVID, that communities self-organizing can be met with great distrust from politicians, which is a type of undermining, and that's a question for that. So my question is, and there goes the question is, who will and how they may address this gap between communities and policymakers?
Is that a question for Ernesto?
I would say that it's a question for everybody.
Okay.
And from my side, what I'm presenting is that there are tools out there that are just waiting to be fully exploited. It's not that you can go and demand from the state in a whimsical manner something because you just wanted to receive some support. You are just demanding the state to honor the commitments that have been made at international major forums like the United Nations General Assembly, where the member states have committed to deliver social protection for people with TB. So it's just as simple as that. The question is, where are we all TB community ready to fully make use of these political weapons, so to speak, right? It's different to demand something when there is not yet a guidance, a technical document, a policy statement, and especially a commitment from the state to honor the implementation of those policies. Here, we are well beyond all that. It's more up to the whole TB community to stand up and demand that all those services are really systematically offered to people with TB. Now, how to do it? I mean, it changes from setting to setting because every country, every community is going through a different stage in history. So I cannot come with a response that can say, well, one size fits all. The critical issue is to work on this, make full use of these tools and these commitments that have been made by the heads of state. Over.
Thank you so much, Ernesto. I see that Riva had the hand up. Riva, would you like to go ahead with your question? And I will come to Ramonde after that.
Yeah, thank you so much. This was really just so inspiring. And I don't know that I'm going to phrase this well, so bear with me. And this was related to some of the things that Dr. Connor Uzma was sharing. Are there, that you know of, and I apologize if I don't, parallel guidelines, like similar to WHO guidelines for treatment, right? Is there a parallel guidance document that would have recommendations for equitable TB treatment? So same idea of weighted guidelines for how to do this work in a way to disrupt the inequitabilities, because there were so many critical points to the things that you presented. I was kind of almost seeing them as this would be a great guidelines and recommendations.
I'm not sure if Amrita can probably, feed into this kind of thing if there are any guidelines that exist. But I would always, my only thing is any guideline that's produced as an implementer, I find that it needs to be I hope it can be read by the implementer. It doesn't be 300 pages, especially when we talk about like equity and things like that, and also have the resources in order to make those equitable changes. Otherwise, it just becomes all in paper. So Amrita, I'll defer to you to answer that point.
So as far as I know, there's no specific guideline for equitable service delivery or other steps in the cascade that Uzma had kind of touched upon. But they're meant to be woven in, right? Maybe Ernesto has a comment on this.
Indeed.
But yeah.
I think that we may fall into the temptation of getting for every aspect in life is something similar to the approach for guidelines on treatment, where we can say the treatment regimen, drawing on the best evidence available, should be composed of these 4 medicines, and you can select from these 8 options, and it applies to whoever has a TB in the Antarctica or the Arctic Circle or wherever. When it comes to tackling inequalities, tackling all these facts of post-colonial approaches in the support to countries that Uzma has presented, it's impossible to have a prescriptive guideline with the level of detail that can suit all needs. However, the guidance on ethics and human rights that I have mentioned in my presentation presents the values underpinning the implementation of the NTB strategy. And it's a debate around the way these values are underpinning the interventions in the field, what should result in very practical local recommendations on what to do, how to do it. But don't expect for WHO to operate like a police force, going from every single corner to see how these values are being implemented at every district level. The task is to use these kind of documents where the values were not selected randomly, but were selected precisely to inspire and drive the way to address the vulnerabilities and the inequities that are behind the TB epidemic, and that quite often are affecting the way the technical support is delivered and presented. When we present in the NTB strategy ethics as one of the core principles, it applies as well to the ways in which the technical assistance is delivered. It's applying to the way the guidelines are crafted and adopted and adapted at local level. So there are tools out there, but they require some local work. They need to be owned by the end users and by the whole TV community that is really concerned about ensuring that human rights are protected. Over.
But I have to say that this is encouraging me to think that there is room within guidelines or within any kind of algorithm that an implementer might be using to think about these caveats, to think about like how are they going to implement them in an equitable way, side by side, as the diagnostic or clinical guidance is given, is disseminated, like side by side, have these other things that they have to think about to just kind of practice equity on a day-to-day basis.
Absolutely.
I think there was one other hand raised, and then we can move on with
Thanks, Amrita. It's Monday. It was actually just, I don't think my video is going to work. No. Oh, look, hi. So thanks so much for all the insightful comments and lots of food to digest. But my question, I think, was the earlier question, which was to Uzma, was just reflecting on that. Ernesto had mentioned that it really is the role of civil society to demand these gaps in equity and be addressed. But I think that there is a risk of communities realizing, which we definitely saw during COVID, that in them actually taking ownership and stepping up, that their cohesiveness is actually met by a lot of distrust by politicians. And I'm speaking like from local experience just during COVID and obviously around local elections and things like that at the time. So it's just with everything that's been said and Vivid's comment as well, it really does seem like there's this gap. There's this role for someone to be setting these indicators for the equity, much like WHO does the technical indicators, because I really am struggling to understand how there would be impetus for a health department, a politician to actually even consider, know about those guidelines and move towards implementing them or acknowledging community justice and community action, if that makes sense to you. And I'm really just struggling to understand how that gap in between politicians and community gets addressed, because I can't see it practically being just the community who's going to bridge the gap. It's a horrible thing to think and say, but and very colonial in itself almost, but it almost seems like there needs to be an external indicator that needs to be met, at least for a while, for people to realize its value. And I'm just wondering where you all think and sit on that. Thanks so much. Out.
Thank you
If
so
I can
much,
go-
Ramanda.
Can I go?
Yes,
Can I-
yes, please go
Okay.
ahead.
So I actually think that's an extremely important point, and that's because we put a lot of, when we try to like shift, we want to shift, create a power shift, but we don't want to make vulnerable communities even more vulnerable, right? Because they're not empowered right now in order to do it. And certainly some of these people, sometimes even I, as a bridge, sometimes I'm not as empowered. I've gotten more privilege and power, and that's why I'm trying to use it. But I do think when we mobilize people on the ground, it's important to understand that they're vulnerable, and creating this pathway around how to bridge this is really important. And that's why when we talk about self-sabotaging voices and other things, I think we need to understand that there's a long-going conditioning that is happening, and it's not going to change in a second. I mean, I've been a part of that as well. And, it's taken me years of unlearning some of those things as well. So I do think that it's important to create some of these targets, indicators, weave them into TB, implementation and strategies, because you cannot hold people accountable domestically, whether it's governments or policymakers and funders, until you do not align that to some money and to some target. And I think it's really important to look at it that way. Otherwise, we're always going to be going back into that we have these guidelines or we have these things, but if we do not align this to something more that makes people accountable, it's not going to happen. So I take that point, and I think it's extremely important to do that.
Thank you so much. Yes, Amrita, over to you.
Thank you. This is great, guys. So please keep asking these questions, because I think this whole panel is looking to be pushed and stimulated to think beyond the box. So maybe Shreya has all the answers. Angela, did you want to introduce Dr. Abimbola?
Yeah, for sure. Thank you for these questions. And if something pops up in your mind, feel free to type it into the chat. We will have a discussion at the end where panelists can have more opportunity to share their perspective. I know the time is short in between these talks, but we have a chunk at the end. So I'm just going to take a moment to introduce our next speaker. Unfortunately, he's not able to be with us today because of the time difference. It's well into the middle of the night for him. So we will be watching a recording of his presentation made in advance. Dr. Abimbola is a senior lecturer and research fellow at the School of Public Health, University of Sydney in Australia. He's also Prince Claus Chair on Development and Equity and Global Health Research at Utrecht University in the Netherlands, and editor-in-chief of the BMJ Global Health. We talk a lot about the importance of interdisciplinary collaboration, and as an interdisciplinary scholar, his research focuses on health system innovation, primary healthcare, global health governance, and decolonization to promote equity and global responses to communicable and non-communicable diseases. So I'm going to be playing his recording, and if you, Amrita, if you can just give me a nod that the audio is working, that'd be great.
Everyone, thanks for joining this session. What I intend to talk about is the non-problem of fragmentation, or to put it less poetically, let's examine how decentralization influences equity in health systems. And I'm going to be talking about this not as a TB person, but as someone who thinks about health systems more broadly, and who has a lot of issue with the assumption that fragmentation is always bad, or that centralization is always good. In fact, often when I'm asked about what view I hold, that I'm afraid most people in my field do not share, it is that precisely, that I don't think fragmentation is always bad. In fact, it's sometimes, if not often, a good thing. And the question that's worth asking then is why, and under what circumstances, and how is it good or is it bad? And that is the argument that I hope to make and urge on you as you think about the question of fragmentation or decentralization in TB programs. So this talk is based on a paper that was published in 2019. It's a realist synthesis of the evidence on the impacts of decentralization on the performance of health systems. And the opening line of the abstract of the paper reads, "One constant refrain in evaluations and reviews of decentralization is that the results are mixed." And the challenge that this paper sought to address is to go beyond this non-problem of mixed results. In fact, the argument was that for any complex intervention, it is inevitable that the results are mixed. But what's more important is to generate evidence to inform implementation, right? Not that, whether it's good or it's bad in a simple way. And as you might have noticed that I'm using the words decentralization and fragmentation interchangeably. They don't mean the same thing, although they often mean the same thing. In other words, in many instances in which we criticize or have issues with decentralization, part of the argument is that decentralization leads to fragmentation. But there are many times in which things are fragmented, not because they are decentralized. So it's important to have that clear. So when I say fragmentation in the context of this talk, I'm actually referring to instances in which decentralization leads to fragmentation, or the issue that we confront and the arguments we have to contend with is that decentralization is problematic precisely because it leads to fragmentation. Now, for those who are familiar with the Bible, I was raised in a Christian home. The opening line of the Gospel according to St. John is that in the beginning was the Word. And I like to think about this in the context of decentralization, that in the beginning was decentralization. In other words, what is natural in the world, as we know it, is that things are decentralized. Often it takes effort to actually centralize things. The natural order of things is decentralization, or in the context of this talk, fragmentation. And often we define and think of decentralization as an intervention, which is right, or a reform, which is also right. But it's also useful to think about it as a phenomenon. In other words, as something that exists without anyone trying to bring it into being. And to think about centralization or defragmentation, as the case may be, as what is indeed artificial. And so when we do that, the question then we are forced to ask ourselves is how and why does centralization emerge? And when and how is decentralization necessary? Often centralization happens in governance settings because some powerful entity has enough power to order that people do things together, or things are brought together in one place. It could be, the imperial edict of an expansionist monarchy or colonial power or dictator. But centralization could also happen because different entities choose to come together because they recognize that there are benefits in sharing resources, and you can think of that in terms of economies of scale. And as economists will describe, you can also think of that in terms of reducing externalities. whether positive, sort of gaining positive externalities, making the most of positive externalities, or reducing negative externalities, as the case may be. But also think of decentralization as being necessary when, as you can easily imagine, the costs of centralization or the costs of coordination are too high, right? In other words, there's only so much that you can centralize. There's only so much you can bring things together. After a while, it becomes more costly to bring them together relative to the benefit of bringing them together. So there are limits, that natural limits to the extent to which you can centralize. Hence, decentralization becomes necessary, or in fact, you return to the default, which I argue is decentralization. There's also instances in which centralization limits the input of key actors at the periphery. Again, the more you centralize, the less likely it is that you are able to, in fact, involve and include people on the periphery in decision-making in issues that affect them, which of course then means that the rational action to take under those conditions is to further relax that centralization, which in essence is often what we call decentralization. So I'm just giving you a sort of a theoretical sense of how one might think about the differences between decentralization and centralization, and in fact, how in many instances it is centralization that is artificial and not the other way around. So how then do you decide when decentralization or fragmentation is good or bad? Well, the first thing to recognize, as I alluded to earlier, is that it's complex. The answer can't be simple. It's not. You can't just say it's good or it's bad. It is good under certain circumstances, it's bad under certain circumstances. In other words, there are contingencies here, and we ought to take those contingencies seriously. And in the review on which this talk is based, we sort of applied an approach to analyzing complexity called the realist approach, which essentially takes seriously the combination between structure and agency, which you might also translate into context and mechanism. Mechanism here meaning the human agency, the reasoning faculty that humans have, and how they then react and respond to their context and how they shape the context. In other words, there's something dynamic and evolving going on here. You can't have a final word on whether something that is so complex as decentralization is good or bad. And with this approach to analyzing complexity, you actually need to make use of theory, or what was called mid-range theories, which sort of is also, again, context plus mechanism equals outcome. In other words, if you're thinking about equity and how decentralization affects equity, the question you're asking yourself is, how does human agency operate in such a way within certain contexts that an intervention like decentralization leads to equity or leads to inequity? So complex, big question, but it's contingent. And there were three sets of constructs or theories that we applied in this analysis, which helped us sort of move towards a place where we could think about mechanisms much more clearly. The first one talks about voting with feet, which is the idea that with decentralization, there is potential for humans, resources, etc., to move from places, from one place to another, depending on where context is more conducive. The second mechanism is what we call close to ground, which is the possibility of using local information that is unleashed when there's decentralization relative to when there's centralization, right? In other words, governance is happening close to ground with decentralization. And the third mechanism that we employed in analyzing the literature on decentralization and health system performance is something we called watching the watchers, which again is the idea that with decentralization, the increasing number of the centers of governance that exist in a system, and with that, you unleash the possibility that one center can watch another center and hold one another accountable, but also that when one center fails, if one center fails, another center can sort of step in and fill in the gaps. In other words, there's something of a backup possibility also unleashed with decentralized governance. So three sets of mechanisms or ways of thinking about what decentralization does in a system that then allows us to break down the potentials and the different varying patterns of equity and inequity that may result with decentralization. So under voting with feet, for example, and this is just a snapshot of the result of the review, I would encourage you to read the full paper to get a full sense of what these patterns look like, really. And I sort of put a screenshot of a summary of the results, sort of the too long don't read figure that we included in the paper. So with voting with feet, for example, will depend very much on the ease of cross-border or cross-sector movement of patients. So again, you can think about a system, you can say the TB sector in a setting is fragmented because there's private sector providers, there's public sector providers. Providers are sort of, each community sort of governs its own provision, so it's different from one place to another. Right? That's true. But the extent to which that affects equity depends very much on the extent to which people or resources can then move from one place to another. If one community is richer than the other, it follows often that the quality of services there are better than another. And also then follows then that patients and resources will actually move to where there's wealth, and as such worsening inequities. But then again, it depends very much on the existing redistributive powers that may exist at the center. In other words, even when things are fragmented in such a way and decentralized in such a way, there's the possibility that the central governing entity can in fact rationally either redistribute healthcare workers, redistribute patient load, redistribute all sorts of things to ensure that even though decentralization unleashes this voting with feet, there is a limit to it and that it's rational and planned, such that decentralization does not automatically lead to voting with feet, and voting with feet does not automatically lead to inequities. The second mechanism, close to ground, again, you can think about a scenario in which, with decentralization, the existing top-down conditionalities that shape, the ability to focus on local and pro-equity priorities within a space are removed, so that then it's easier and possible for local actors to focus on local issues, which can then reduce inequity. But there are also instances in which the further down you go, the more liable it is that the system is controlled by the elite, which of course then often leads to low quality of services, or in fact it's a scenario in which those who are already wealthy benefit from the services and those who are not do not. Again, the possibility that close to ground, whilst it could improve equity, could also lead to inequity. So again, it is not given, it would depend on the context. And the third one, which we call watching the watchers, again, with more centers, there are more overlaps. There's more possibility of backup. There's more possibility of one center holding the other accountable. Again, you can think of this in terms of the national government, sort of a state or sub-national government, the district government, all involved in one form or another in the TB program, so that if the national government fails, the state government could step up. If state government fails, the district government could step up. If the district government fails, perhaps the community group may step up. In other words, with decentralized governance, there are many more centers of authority, which means that there could be backup, overlaps, etc. But again, this depends on the relative strength of those centers of power. It depends on their relative autonomy. In a setting in which the state government relies on the national government for everything, if national government fails, it almost means that the state government fails as well. So it doesn't translate so easily and readily into the ability or the possibility of reducing inequities. Now, there are also, again, the possibility that community level boards and health committees could also promote accountability in decentralized settings because they are closer, perhaps, potentially to the level of governance that that determine the nature of services that they receive. But again, it depends on the level of the strength of these community level committees, who is on the committees. Are they equity oriented by their nature, or again, are they liable to elite capture, just as I mentioned under the close to ground mechanism? Again, in other words, nothing is given. These are potentials, these are mechanisms. It depends, their manifestation and their effect on equity and inequity depends very much on context. So as much as we are focusing on the mechanism, we're also asking ourselves what's happening at the level of context. So the next time someone you hear someone say fragmentation or decentralization is bad or good, it's important to ask them by what mechanism is it bad? By what mechanism is it good? And to also further investigate and ask questions if there are contextual factors that perhaps worsen or limit the extent to which it is good or bad. In other words, What I'm encouraging you to do is not take a simple characterization of fragmentation or decentralization. Again, do the same thing with decentralization. Ask about how, under what circumstances it is good or bad. And to note, I think, in conclusion, that the answer is always somewhere in between. Right? It's neither wholly good, neither wholly bad. And the question is, how do you calibrate the mechanisms? How do you calibrate the implementation in a way that maximizes what is good about decentralization or fragmentation and minimizes what is bad about fragmentation or decentralization? Again, when you're thinking about voting with feet, you're asking yourself how much central coordination is necessary, how much is too much. If you're asking about close to ground, how close to ground is too close? And again, what actors are there so close to ground? Is the capacity there to use information, local information? Is there appetite for pro-equity actions, reforms closer to ground or not? Again, you're asking really contextual questions. Same with watching with the watchers. When are the centers of governance too many, that it's chaotic? When are they too few, that you can't rely on them to sort of fill the gaps of inequity when the center perhaps does not function well, or where the center does not cater to the needs of those who are least advantaged in a particular setting? So what I'm encouraging you to do, and I hope you do in the following discussion, is to really think deeply about the TV programs you're familiar with, the national TV programs, the subnational ones, and ask yourself, is it too centralized? Is it too decentralized? Why is it centralized? Why is it decentralized? How do you sort of recalibrate the extent to which it is fragmented or not, so that you optimize equity in the program and in the system? Thank you very much for listening, and I hope you have a great discussion.
Okay, so while Dr. Abimbola is not here with us, we still want to kind of open up the floor for any discussion based on what he's talked about. And just a note here, we did note down your question, Victoria, and we'll circle back to it when we get to the big discussion at the end. But if anyone has anything they would like to share or comment on regarding the presentation we just saw, let's do that now.
If I may, I think that my question is actually really related to this presentation, because what we're talking about is decentralization and wanting to include local voices. But it's hard to even know where to start, because as Dr. Abimbola was saying, centralization limits the inclusion of actors at the periphery. And that's what has actually happened. And to the point where we are having trouble even identifying who those actors should be and how to engage them, because just starting with the healthcare providers, those are sort of the first place where we might start, because we already know who they are and where they are. But we even find that a lot of the healthcare providers who work on TB, they are sort of reluctant to speak out about TB because it's so stigmatized. And they haven't been engaged they haven't really been practicing, engaging that and been invited before. And at the community level, there aren't a lot of community-based organizations either that have worked on TB in the past. So in a situation like that, and now I'm speaking about Vietnam, that's where our program is, I think it's just a really practical question of how do we start to build up that momentum and bring those voices to the table.
Thank you for that, Victoria, for raising that. Would anyone from the panel like to respond, or would somebody from the audience like to comment and respond as well?
So I can make one comment, especially since this is really, I'm passionate about the decentralization topic, because I see that that's something that we struggle with, because everything is very centralized. And so when you say that civil society organizations are not involved and or are not involved in TB, I think that's the main issue, that they're not going to be involved until we create avenues to, make them active participants. And that will not happen until we do activities in a more decentralized way, which are more near patient delivery activities. So that, and I think it speaks to health literacy, it speaks to not just having active contribution, it speaks to destigmatization. So until that's not going to happen, and the reason why I think I really liked how he phrased it, that we have like moved the natural form into an unnatural kind of way in the centralized thing. I think it's important to kind of do that. It went to centralize more because of control, because of lack of resources in decentralized systems to address some of the TV services deliveries. So, but I think that there is, while the policy now talks about implementing more decentralized models, I think it's the resource gap that exists, which does not allow for them to get more resource. So I think if we start doing it, and I think there are activities that are more mobilized, more community level that are happening, they just need to become a little more, there needs to be more momentum shift in that. And once that happens, the community itself will participate, and there'll be more civil society organizations that will become a part of it as well. So it's not a solution, but it's just more of that it needs to, we need to continue to decentralize activities.
Thanks, Uzma. If I may, I'll just jump in here. I think that really shows nicely also your example, Victoria, how difficult these processes are. And I think that what this talk really reminds us of is that there are no easy answers, and we should sort of be a bit hesitant to just believe in easy answers. Fragmentation is the answer. So no, let's question in what situation actually can we go for decentralization, and what type of resources would we need to really be able to decentralize, right? He was talking about having these sort of redistributive authorities to make things work. So I think what this talk, I think, nicely shows, and in a way also links to what Ernesto said earlier, is that it's a very nice reminder to pay very close attention and take a very close link at these dominant discourses, and just accept that results will always be mixed if we're talking about these type of complex interventions. And he talked now specifically about decentralization, but you could take any kind of intervention in tuberculosis, which always comes with some form of centralized or decentralized idea attached, right? How we're going to implement this thing. Is it going to be done in the periphery or more centralized? Are we having a testing, a laboratory system that is organized through reference labs or in the periphery, etc.? So you could apply that to any of these interventions. But then my question is, how can we encourage, and this is where it links nicely to changing the discourses, essentially the medical discourse, where there's often a very clear answer. This is the best way to treat a person. This is how you have to do it. So how can we encourage policymakers, funders, but also researchers to accept and embrace that there are often no easy answers? And how can we facilitate this type of more nuanced understanding and thinking and questioning around interventions as well? Whether it's, am I going to decentralize or not? Am I going to implement this technology or not? And just accept that there are always mixed results. There's always going to be aspects that work for one part of the population and others that don't, right? I know most things about diagnostics. So the gene expert brought some good things, while it also brought other things. It created new inequities, but it also ameliorated others. And so then how can we move away from this type of thinking that there are easy recipes and that if we follow them, things will be okay and we will always have good results? I think you find that thinking everywhere, in the science, in what gets published, how it gets published, how results are promoted, in the guidelines, and maybe also, in all those junctions and friction moments that Uzma so nicely presented earlier. So I think that's a really nice reminder that Shay's talk highlighted. Sorry for taking so much time.
Thank you. Any other thoughts, Ernesto?
Thank you, Rita. I mean, thank you for this presentation and for the feedback from all of you and from participants. Just a few seconds to make further echo to what Nora has said. At the end of the day, in every single thing in life, in our personal lives, in the community life, in global life, it's a trade-off, right? Because we cannot get everything we want without having to negotiate and pay a price for it. But the fundamental issue here is whose interests are going to be most badly affected as a result of a decision? Where are the benefits? Who can gain most benefit out of one option or the other? And here is where I insist, we need to put in action in the debate, what are the fundamental values that should be inspiring the response to tuberculosis, and how to ensure that the needs of the most vulnerable people of the society are protected. If the decision is, let's go for example, decentralization, because that is the most effective way to save money. Is it that saving money is the fundamental value inspiring the response to TB? Nowadays, nobody is questioning the idea of treating people with MDR-TB. But the response to multidrug-resistant TB was not built on saving money, but on values. People with MDR-TB in every corner of the world does deserve to benefit from the best technology available in the world, regardless of the place where they are living. It was totally value-driven. How to materialize that? So the debate has to be inspired by debates. Sorry, the debate has to be inspired by values that can protect the human rights of vulnerable people in order to reduce inequalities instead of perpetuating or amplifying those inequalities. Over.
Thanks, Ernesto. Mike, welcome.
Thank you. I was just thinking about the centralization and fragmentation discussion in relation to civil society. And as a member of TB civil society from the global north, I think these same tensions between centralization and fragmentation and the same structural issues that were presented in the last talk, are repeated within kind of our own civil society structures, which makes it difficult and worth thinking about. And there's, an intense pressure, I think, among civil society and especially groups doing advocacy to hew to a single message, to have a unified voice, to compete for a limited pool of donor funding. I think that often there's pressure applied from donors for groups to work sort of individually, to have clear wins that we can trace back to the work that we do rather than work in coalition, which is sort of our natural orientation in civil society. A lot of Uzma, what you had in your talk resonated with me kind of on the other, side of the sector. And these are all challenges. And we often in civil society have our debates and conversations with our peers in public where our donors are listening, watching us. And I'm not sure how to disrupt these dynamics, but I think they're very real. And it's worth thinking about how do we build a movement and what would be required to have kind of solidarity, to allow groups, community groups in Vietnam to come into the TB space, to have a voice within it, to be supported, to have an agenda that may look different than a community group in New York or South Africa. And so we've come a long way in 10 years in civil society and TB, but I think we haven't solved some of these structural issues that are now very much present on our side of things as well. Thanks.
Thank you, Mike. Thank you. So I think unless someone has a question, I was wondering if we could just take a short break, stretch our legs a little bit. So let's come back at, I guess it's 8:39 my time, I guess in about 10 minutes, yes? For Yulia and Grania's talks.
Back, everyone. Welcome back, everyone. It's my honor to call upon our next speaker, a global leader also in global TB advocacy. Yulia Shona is a TB advocate with a background in social work. Through leadership roles in civil society and TB advocacy groups, Yulia has supported community voices in TB and HIV to bring a people-centered perspective into decisions related to effective quality care. She consults on multi-sectoral collaboration and accountability to end TB with the WHO Regional Office for Europe, TB Europe Coalition, and other governmental and non-governmental partners in the countries of Eastern Europe and Central Asia. She has also been a member of the WHO Civil Society, a task force on TB. Julia, over to you.
Thank you, Jeremiah, for this warm introduction, and good morning, good day, everyone. I'm happy to be there. I will now share my screen. Do you see my slides okay? Yes.
Yes.
Okay, great. So in my presentation, I actually will cover the issues of social determinants of tuberculosis as related to equity, and also share some examples of multi-sectoral collaborations to address equity dimensions. And to start with, I would like to come back a little bit to the definition of equity and expand my argument from here. So at the slide, you see the United Nations definitions from the actually from this ethical guidance on tuberculosis, which was mentioned many times by Ernesta. So I would just want to say that although it's UN language, I was glad also to see in the chat that it appeals a lot with what you were writing. Yeah, because health equity means that people can reach their full health potential as a human right and should not be disadvantaged from attaining it because of their race, ethnicity, religion, gender, sexual orientation, disability, age, social class, socioeconomic status, geography, and other socially determined circumstances. So many of you address it in your chat responses and also address some specific points of this definition. And again, equity is one of the underlying principles of the WHO NTB strategy on protecting and promoting human rights, ethics, and equity. I just want to stress there that it shouldn't be confused with equality, which means that everyone gets basically the same in terms of support and resources, because we all know that everyone cannot be at the same position to begin with. Yeah, people's circumstances are different, and to achieve equitable health outcomes, the one who needs more gets more, and this is then related to justice, and this is then related to redistribution of wealth, and this is just then related to fairness. As achieving equity and fairness means recognizing initial unequal positions of different people because of how society structures work in forming and reproducing social stratifiers. I would like to touch upon the social determinants of health. And here in the slide, you see represented the framework, which is a conceptual framework for action on social determinant of health, developed by WHO in 2010, and which is linked to their work on the Commission on Social Determinants of Health in 2005-2008. I actually myself very often refer to this framework when I do like policy analysis and some work on planning interventions, and I think it's very comprehensive. My only concern, and actually, yeah, I'm sad that it's still this framework. It's very nice, but it's still adequate since 12 years past it was first developed. So that means that the circumstances and conditions of people's lives are not changing much in a good direction, despite all this like STEAM work on sustainable development goals and activities in this area. So in the frameworks, you see on the left side structural determinants of social of health inequities, which are basically very much linked to socioeconomic and political context at the macro level. So it means governance, macroeconomic policies, social policies of labor, market, housing, land, and public policies of education, health, social protection, as well as culture and societal value. They determine the socioeconomic position of of people. Yeah, so that basically forms the condition in which they grow, work, and age. And then on the right side, it's intermediary determinants of health, social determinants of health. And those basically relate more to material circumstances, behaviors and biological factors of disease, and psychosocial factors. And in many health interventions, there is a tendency to address this these social determinants of health, which are intermediary, which is more like a risk factors, because it is more feasible to address them, and you can like mostly see the impact. But if we do not do the like high level policy advocacy also to ensure the universal social protection and universal social health coverage, which relates to the structural determinants, then addressing only this like intermediary risk factors would not be sufficient, yeah, because it will not change the situation, it will not change the status quo of the social determinants of health. I would also want to comment on these structural determinants that they are very much linked to the current macroeconomic policy space, and it is determined by the fundamental reliance on market economy and also on politics of austerity, which is often experienced by countries who are recipients of international loans and international monetary support. So this politics of austerity, it basically limits countries a lot in investing more in social protection and investing more in health and education. All the social determinants are kind of not considered to be the priority, because it's more like market profit-driven approaches. So basically, without this very high-level advocacy, without negotiation, without pressure on international monetary organizations in order to lessen this politics of austerity and to allow countries more equitable health in terms of grants, for example, and this kind of assistance, it's very difficult to shift the status quo at the country level in addressing the social determinants and securing enough financing from the national budget, national public budgets, to ensure social protection and to ensure universal health coverage. Having said that, nonetheless, I don't want to diminish importance of addressing downstream factors, risk factors. This relates to like direct tuberculosis determinants and vulnerabilities, and they include the risk associated with prevalence of TB in the community, tobacco use, and other conditions. Based on global estimates, WHO attributes TB to 5 major risk factors, such as alcohol use disorders, diabetes, HIV infection, smoking, and undernourishment. There is quite a recent framework for collaborative action on tuberculosis and comorbidities, which provides a lot of very helpful practical information on strengthening multisectoral and multidisciplinary approach within and beyond the health sector in order to address these risk factors. So why a multisectoral approach for tuberculosis makes a difference? Again, because exposure to TB infection, progression to TB disease, and risks of disrupted treatment are conditioned by social determinants, of which I was talking before. And basically, we need to understand individuals' needs of every person with TB, and also these needs are shaped by equity dimensions, and to plan intervention which health sector alone and national TB programs alone are not able to address because of their mandate and also because of the financial streams, like of financial budgets at the country level. So it's very important to ensure the approaches and tools which bring stakeholders beyond health at the negotiation table, at the discussion table, for joint advocacy at the country level, for budget advocacy, and for mutual joint activities, sector-specific targets, and accountability. So I would like to introduce a tool, maybe many of you already know it. It's multisectoral accountability framework on tuberculosis, which was developed by WHO on inquiry of member states after United Nations high-level meeting on TB in 2018. And of course, it's not like a magic bullet. It's not a solution for all their gaps in the multisectoral collaboration beyond sectors, but it's a very effective tool to steer the discussion in this direction and to start working for strengthening of cross-sectoral collaboration and cooperation. So this tool, this approach, it includes 4 basic components, which are commitments, which countries and head of states are making at the global level, for example, when they sign different political declaration, or when they adopt the strategies like an NTB strategies, sustainable development goals. And then these commitments at the country level, they are transformed into actions. So basically how they are implemented in order to reach these targets. And here on the slides, you see the key multi-sectoral actions which include development of national multi-sectoral tuberculosis strategic plan, meaningful engagement of civil society, engagement of private sector, promotion of integrated people-centered TB services, and legislation that are ethical, people-centered, and equitable, and also other dimensions. Then there is an element of monitoring and reporting, which includes routine reporting and reporting on TB by national TB programs, monitoring of indicators on social and economic determinants of health and risk factors, different kinds of national surveys, annual reporting to WHO, and national annual report on tuberculosis. And then there is this element which is called review, which includes both periodic high-level review, which ideally should be held with the leadership of the head of state and the head of government, and in order to have like this political will to enable cross-sectoral approach and budget financing for addressing TB, and then also external independent reviews. So countries which adopt multi-sectoral accountability framework on tuberculosis, they start with a baseline assessment checklist to track how collaboration and accountability work beyond the health sector. And the checklist guides analysis on the translation of commitments to national policies and related targets. And here on the slide, you see the checklist and the link where you can find it also on the WHO website, as well as annexes. So these annexes, they specifically address assessment of governmental ministries and bodies engaged in TB, and engagement of civil society and affected community in multi-sectoral response, and adaptation and implementation of WHO tuberculosis guidance. I would like to share some example of work on implementation of baseline assessments with the use of Annex 2 in 5 countries of Eastern Europe and Central Asia, which were done in 2020-2021 with their regional cooperation enabled by TB Europe Coalition and technical support from WHO Regional Office for Europe. So these were assessments in Belarus, Kazakhstan, Moldova, Tajikistan, in Ukraine, with broad protocol of national partners involved, and basically what is important also in this baseline assessment, that they then have a potential to be further used for informing national TB program reviews, development of national TB strategic plan, and funding requests to the donors, including the Global Fund. When we worked for this regional assessment, we operationalized the multi-sectoral accountability framework and added like complementary qualitative and quantitative data collection tool to collect the information from civil society and affected communities, and to analyze what is the meaning of multi-sectoral collaboration and accountability for civil society and community partners, as well as to solicit information about perceptions about accessibility of TB services and barriers to access of TB services, as well as what should be priorities to improve TB care and reach equity priority populations. Just like very briefly, there were four main thematic areas which were addressed by civil society through these assessments, which they perceive like important for meaningful engagement. And first is a safe environment for civil society and community to voice up any suggestions and concerns to authorities and decision makers to address barriers and access to care for people they serve. Then it is engagement in the decision-making processes from the planning to conceptualization phase, not only at the late phases, impact on the decision and policies made by civil society through the engagement of the associated process, and sustainable public financing to support operational activities and deliver services to people affected by TB. Because basically now in Eastern Europe and Central Asia, most of the services, social support services, are provided by civil society organizations with the donor funding. There is no still functional, sustainable mechanisms of procurement of these services from public budgets. But that's also like a challenge, especially if you consider the transition of donors from the region. And here I would just briefly would like to show also the findings which were related to social determinants of health, which were found across the countries. The frequency and intensity of these findings were different in different countries. So these examples are provided just as an illustration of particular challenges which were manifested in some sites through although they varied substantially across the different sites. So again, they were like these determinants as stigma, with domestic and community violence, social exclusion from the community, discrimination, which considered expulsion from work, school, housing, poverty, as food insecurity or lost housing and non-financial means to pay for transportation to healthcare facility. Unemployment, which was related either to lost job, lack of job opportunities and lost profession, and also a lack of awareness about social entitlements. Even if there were this social protection mechanism and legislation in the countries, like not to be specific, but something on housing separately, something on retirement, something on disability, in many cases, people were not aware about these entitlements and social welfare subsidized. And also the gender biases. And also there were revealed some structural factors which related, first of all, to the mandatory documentation identity papers, which basically means that if people didn't have identity papers or records, like residence registration or passport or social medical insurance, they were not able to access the services in time. And there was also issues of conflicting policies, drug shortages, lack of referral mechanisms between services, and poor infrastructure, like, for example, poor quality of road, which was difficult to people from rural areas to get to the points where they can access medical care. So this is just like an overview to show this social determinants of health, which are linked to inequality, and basically results of this assessment leads to the equity-oriented, the call for the equity-oriented approaches. And this slide outlines some summary of the needs of people with TB, and also the call for legislation for equity, rights, and ethics to be interwoven with all the legislation for TB and all policies for TB, and that it will, like addressing all these different needs, assessing these different needs, will basically help to promote equity and promote people-centered care. And to enable equity-based approaches to end tuberculosis, it's important to include these dimensions in TB research, in policy planning, actions, monitoring and reporting, and progress review, also as related to multisectoral accountability. And basically addressing equity, ethics, and human rights within the discourses would have this implication for promotion of general socioeconomic, cultural, and environmental conditions improvement. And in terms of windows of opportunity, we know that we are now at the age of 2023 comprehensive review of head of states and the United Nations high-level meeting of TB. So there are the preparation which already started to this meeting. It will be like a high level with heads of states and heads of governments participating. So it's very important to think now how to formulate the call to action to the governments, to the donors, to all the high-level political leaders in order to promote equity dimensions in TB response. Yeah, and that's it, basically. Thank you. And I would like to acknowledge my colleagues with whom I collaborated for multisectoral accountability framework work, Serhan Hasanova from WHO Regional Office for Europe, and TB Europe Coalition team, including regional expert group and country partners, including in assessment in IPA region. Thank you. That's it. Thank you.
Thank you so much, Julia. So we will take, I hope if you can hear me, we'll take a few questions, maybe one or two questions from our listeners. And as before, please, if you type in or you raise your hands, and we can see you. So Julia, you one of the a key message that you kept re-emphasizing was that TV must involve all the different sectors, and you laid it very well in a very digestible format. How could we, just within this, how could we envisage accountability in this dynamic? What could just be some of the challenges regarding ensuring there's accountability when these different sectors work together?
Yeah, thank you, Jeremiah. First of all, it's very difficult to engage all the sectors, to begin with. There are like some traditional sectors, for example, like civil society and like Ministry of maybe like Ministry of Interior or Penitentiary Service that are engaged in TB response, particularly in ICA, also with the support of Global Fund grants. But it's very difficult to create this appealing message, let's say, for the Ministry of Education or not like very traditionally involved sectors to be involved. So in order to do it, you need like facilitative platform to bring the stakeholders together. In ICA countries, when we had the assessment, such a platform most often was this country coordinating mechanisms on the Global Fund grants to oversee the Global Fund grants, but basically most of them, they have broader functions. So this is how the people are brought together at the first place. And then there should be joint planning and engagement of all sectors in the joint planning and targets, and also advocacy box to ensure financing of these services right, through different sectors. Then, so it's very important to create this environment, like bureaucratic environment, which would support this movement, but also funding to support the implementation and accountability of the sectors. That's why these high-level review mechanisms are very important, including like parliamentarians, head of states, head of governments, both in the country level and both at the UN level, in order to create this political agenda, political priority for TB.
Thank you, Yulia. I'll just go to my fellow panelists if you have any questions. Any of the panelists?
I don't have a question per se, but I do think that the next talk might respond to some of these challenges and some of the issues that Yulia has raised. So thank you, Yulia, for that.
Thank you.
Thank you, Amrita. And thank you so much, Yulia. So we'll go straight to our next talk. Over to you, Angela.
Great. Yeah, I have the privilege of introducing our last panelist here, Grania. She is a senior TB advisor at the Global Fund, working in the strategy investment and impact division. She has over 15 years of experience in service delivery, programming, and research in TB, including drug-resistant TB, child and adolescent TB, and TB comorbidities. Among her various leadership roles, Dr. Bridgeton has been TB and AMR advisor for Medicine Sans Frontiers and director of TB at the Union, where she helped to shape the global TB research and programming agenda. She has played a key role in TB knowledge translation, including developing TB science at the annual Union conference, which I'm sure we're all familiar with. So I'll pass it on to you.
Thank you very much, Angela, and thank you to the organisers for inviting me to speak today and proposing a good provocative title for my presentation today. And I'm following some great speakers, and some of the things that I am including today maybe respond to or build on the presentations we've had today. So, I mean, I think as Yulia said, sort of, we're not talking about inequalities. We're talking about inequity, and I think we just have to be very clear from the start that kind of equity is not a nice to have. It's fundamental, and we have to address it, and we have to prioritize it, because without prioritizing it, we are not going to achieve any of the NTB goals, or more broadly, the sort of wider SDG goals. So I think that's just really to start with that. And so what is the state of inequity? I mean, I think it's quite clear, and a number of the speakers today have highlighted some of the key areas. And a report done last year with the Global Fund and the World Health Organization reiterated that. So the state of inequity in the three diseases, HIV, TB, and malaria, the poorest, the least educated, and the rural were at the most disadvantage. And with regards to knowledge of TB, again, the poorest had the lowest index for this. For the catastrophic costs, the poorest subgroups suffered much more catastrophic costs than the richest subgroups. So these are all things that I think we sort of know, but the data just back that up. And I think what's important here is that kind of realizing that if we can eliminate some of these inequities, it would have a really positive impact. So, you know, eliminating eliminating the percentage of families facing catastrophic costs, you know, could play a key role in improving in sort of inequity for men and women in the weighted averages. So, and so to the question, kind of, should funders be involved in equity? I mean, I think everyone should be engaged in equity. There is no one exempt from thinking about it, prioritizing it, and thinking about what role they can play to address it. And I think the other thing to think about, or that sort of underlies a lot of conversations in TB and approaches in TB, is we are operating in a very resource-starved area. So as you can see there, the target for addressing the TB issues is 13 billion, and we are nowhere, we're not even halfway there. And donors do play a role, but actually countries are funding the majority of the TB response. But we all need to advocate for more funding, and we all need to think about how addressing inequities within that funding is done. Just a quick say, sort of, why Global Fund? We play a large role in the international financing for TB. So this is something that is very important to us. So I'm going to slightly make this personalized about the Global Fund, but I think some of these approaches could and should be thought about by other funders in the in the TB area, but really talking about what experience we've got. So going back to sort of thinking about inequity as being the distribution of health that is unjust, unfair, or could be avoidable. These are some of the sort of approaches of thinking about how we can improve equity for TB. So, you know, targeting the services, really making sure that we are targeting the services at those most in need or those most affected by inequitable situations. So kind of really looking at the data of the program, looking at physical access. So kind of how are we going to address that inequality in the rural areas? So getting health facilities or health services to the remote areas, how to empower community health worker programs, and thinking about the role of mobile teams and outreach. And I think that's particularly as technology becomes more portable, more decentralizable, kind of how can that facilitate addressing some of the physical access barriers that exist in TB. Then there's the economic access. So kind of making sure where there are user fees to access healthcare programs, that these are removed, because particularly, again, looking at that health inequity report, where catastrophic costs are disproportionately felt by those who are poorer. We need to reduce barriers or economic barriers to accessing cares, and we need to support or minimize catastrophic costs for staying in care. So sort of thinking about cash transfers, food vouchers for keeping people and supporting people through care. And then really working, as Julia was saying, sort of looking at what other partner organizations can be supported to explicitly address the needs of those who are most affected by inequalities. And then cross-cutting really, and I think picked up by a number of our speakers today, is to have a look at the sort of gender and human rights barriers that exist for TB and more generally. So kind of this empowering of the key populations to make sure they know their rights and how to reduce the stigma, and looking at the role of community-based monitoring to improve the quality of services, and I think to sort of give the community a voice in addressing change. So just sort of quickly, this is reiterating a point, but knowing where you're vulnerable or your groups that need specific outreach are, it changes context by context. You can look at it from a population, like from a country base to a regional or district level to really ensure that you tailor interventions to those who may have problems accessing care. And then I think really to kind of talk about community systems, and I think these do play a really key role in addressing issues with accessing healthcare. And I think it can be done in a number of ways. So there's the formalized community responses within the health system. So community healthcare workers, and I think to echo the point that's been made, is that to make sure that they are budgeted for and that they are adequately remunerated for their work. And then there's the community responses that are partially captured under the health system. So these may kind of be looking at health education, looking at adherence support, sort of and this decentralizing and kind of how that looks. And then I think there's the sort of third bucket of community responses that are outside the formal health sector, and that's the ones that are kind of probably a lot of times driving the root causes of inequity. So the social determinants that Julia so nicely highlighted, sort of how to engage the community and support them in addressing these social determinants and looking at social accountability within that. And so Global Fund has funded a number of things, sort of community responses by community-led organizations and community health workers, and then looking at sort of strengthening the systems that are required for effective, resilient and sustainable community-based services. And that sort of leads us on to, I think, the other question that is more kind of, Global Fund is looking at HIV, TB and malaria, but it needs to increasingly kind of has recognized the role of health system strengthening, or really more about the resilient and sustainable systems for health, and the really key role that they play in supporting some of the TB specific funding and the TB response. So, and it's kind of looking, and that taking the resilient systems rather than health system strengthening, I think is trying to encapsulate not just kind of, say, for example, diagnostic systems, but the services that are provided, as I was showing in my last slide, not quite in the sort of mix within the health system or completely out with, and making sure that there is an acknowledgement of that and a potential for funding for that, so that with the aim that individuals' healthcare needs are met wherever they seek care. And so a recent sort of looking back on previous global funding on health resilient and sustainable systems for health investment within which could be supporting TB programs, services and response. There's actually been an increase of nearly half between the last two global fund cycles on the more health system strengthening component to our TB grants. Of these investments, 60% were enabling investments and 25% were directly into community systems and responses, as well as capacity building interventions. And maybe to some of the comment around sort of the building potentially awareness and ability to contribute to national conversation on sort of looking at 15% of these of the RSSH interventions are in capacity building, which was increased up to 30% in the last funding round. So really we're seeing here is that if we look at the investments that the Global Fund made in TB in the last 6 years, so the last two cycles, apologies for the acronyms, but NFM2 is New Funding Model 2, which was the Global Fund funding round prior to this, and NFM3 is the current Global Fund supported programs. And what you can see there is that this acknowledgement of RSSH as an important part of the TB response is showing that it is, has increased over time. And the MDR sort of decrease, I think, is due to some of this cost savings in drug costs just before, just as something else. And so that's what we've done in the past. So I'm now moving to the future. And this is where the Global Fund has put equity front and center of both our vision and mission in our new strategy. So it is key to the work that we want to do going forward and building on the work that we have done in the past. And I think, as Julia pointed out, the country dialogue process is the start of any Global Fund funding request, and it is a key part of the Global Fund process. And it should ensure, as we show here, that it has a full range of affected and communities and stakeholders involved in the three disease programs to really ensure that what the national issues are brought to the fore, and that everyone has a voice. And it is ensuring that there is a transparent and inclusive process in the building of a Global Fund funding request is part of the CCM's terms of reference. So really, this is a key, hopefully a key area where inequities can be raised and a dialogue had about how to address them. And I think, to my earlier point, we are working in a resource limited setting. We unfortunately don't have all the money we need. So there does need, there may need to be a prioritization process done. But I think, to Ernesto's point earlier, the role of national documents such as NSPs and putting the effort into national strategic plans making sure it sort of has a full inclusive process, and then can allow for a conversation about prioritization if needed, and also be used to mobilize resources for areas that may not be able to be covered by Global Fund, I think is a really key point that should sit outside any Global Fund process, but can very much support and feed into any Global Fund for those countries who are eligible, into any Global Fund requesting process. Just going on to the strategy again, there's been a slight change in the TB. The sub-objectives for TB have expanded. So, and as you can see, equity and people-centered approaches is a key here. So we continue with the Find, Treat, All through equitable people-centered approaches, focus on prevention, focus on quality, focus on innovation, and rapid deployment of new tools or new guidance, very much so. And then this cross-cutting sort of enabling environment. And this is really key. It is one of our 5 strategies, is ensuring that we are also addressing some of the drivers of inequities. So next year, 2023, is the beginnings of the next funding round for the Global Fund. And so there's a lot of information available, updated information available online on the Global Fund pages to help countries start the preparation process, the country dialogue, as well as thinking about what they can include in their funding requests. So the TB information note is a very good place to start. And there are key areas around equity that very clearly state that the Global Fund can support. Another thing I just want to bring up briefly, because it's new, is the inclusion of TB program essentials. And these are just key areas that the Global Fund feel that could play an important role in countries achieving their national TB targets. They are based on technical guidelines from other partners, particularly the World Health Organization, and we sort of feel that they are essential to ensuring equity in access. So addressing these will hopefully ensure that not only will the TB outcomes be achieved, but they will be viewed and achieved with an equity lens. So there's 5 key headings. I'll just there's key areas on TB screening and diagnosis, TB care and treatment, TB prevention, and these are all in the info note, which is available online, TB HIV. And then I just wanted to pause here a little bit of kind of going to the point of the more technical areas. There's also a really key area on the cross-cutting. So ensuring that sort of we're addressing the gaps in the care cascades. We are engaging healthcare providers, including the private healthcare. We are looking at decentralized, community-based, people-centered services. We are looking for and addressing the human rights, gender-based inequalities, looking at stigma and discrimination. We're looking at justice and community mobilization. So these are essential to a good TB program and are outlined as such. As I said, there is lots of information already available and coming available on the Global Fund website. So please do go. And yeah, so I just really wanted to end by thanking all of the speakers today for setting up. It's been a great session, but I think just really to end that I think everyone has a role to play in addressing inequity to ensure that we all work together to ensure that no one is left behind. And thank you very much.
Thank you very much. That was a great talk. If anyone has any questions specifically related to this talk, we'll address that now, or any comments. Yes, go ahead, Buka.
Thank you very much, Grania, for this talk. I don't know if everyone can hear me. Yes, so just to appreciate the efforts, my name is Ebuka, and I work in Zankli Research Center in Nigeria, which is very much in the academia. So in terms of the TB program, in a sense, I'm just like an active sort of observer. I look from outside. And I can see certainly like from in the past 10 years, looking at the Nigerian TB program, in the earlier part of the last decade, the Global Fund will go to sort of NGOs that are the principal recipients, and then more NGOs are sub-recipients. And many times, within the 2-year grant implementation cycle, we've not even sometimes done the DOTS training due to the sort of bottlenecks in accessing these funds. It was assumed that these NGOs had better accounting, financial auditing systems. But I've noticed, I think in the last 5 years, and this is kudos to the Global Fund, they've, I think, sort of changed their posture in terms of now directly funding the National TB Program of Nigeria, essentially the government as the PR. And if you watch in the past few years in Nigeria, so the state governments are now the sub-recipients. There's now a very high level of ownership. And if you look at the performances, I think they've risen to March. And so despite the COVID, so you find that really resilience is local, right? Resilience is local in nature. So I think when I hear about equity and the role of funding institutions in achieving equity, it has to do with power. It has to do with giving up power for those who currently have it. And then giving time for those who are new to the experience of owning the power to actually digest it and then begin to leverage on it to cause the needed change. I think this is just to say, to commend the Global Fund as well. And I've seen in Nigeria the dramatic improvement in performances, particularly in treatment coverage, TB case finding, that has improved since. And then generally, the program has begun facing upwards since this funding model began to fund government directly. I appreciate it's difficult because sometimes trust, finances, value for money, and those sort of arguments. But I think essentially resilience and equity resides locally. Thank you very much.
Grania, did you want to respond?
I mean, I think just, I'm not sure there's a question in there, but I mean, I think I also want to echo that the improvements and the work of the Nigerian NTP and MOH has been really sort of, well, it's been spectacular. And I think, yeah, and that's something that, Global Fund facilitates, but it, as you said, it rests and it owns with the NTP of Nigeria. So if there's any representatives from the NTP Nigeria here, I think your work is being fantastic. Thanks.
Thank you for raising the point, Ebuka. Thank you, Grania. Any other questions from the audience for Grania before we just move into a broader Q&A? Nora?
Only if nobody else has a question. Grania, thank you so much for your talk. It was really insightful. And of course, as an outsider, you always wonder, how do these processes function and work in practice? So I was just wondering if you can just maybe from your recollection, give us some example of, or an idea how this works, this negotiation of different priorities, because as you said, you don't have all the money you want. And even within your priorities, the list that you now presented, even among the essentials, there's already trade-offs to be made. You can't grant access to everybody and also fund all these or do justice to the different barriers that people have. So I think when we, when we're talking about more equitable solutions, we might require, and we've heard this from the other speakers, to strengthen systems, work across diseases instead of vertical programs, use technologies for multiple diseases instead of just for one, place them in areas where there's low utilization. And all of this might go against traditional priorities and indicators and targets of donors as well. So I was just wondering if, as Ebuka also mentioned, these things are owned and the resilience is local. Are there some examples that you can share with us of reaching a middle ground in these discussions between, say, in-country planners and donor-funded partners?
Yeah, I mean, I think so. I'm trying to sort of think of there's the conversations that happen at the Global Fund Secretariat when we have the funding envelope, and in fact it's the board meeting this week right now, two stories down from me, who are sort of tackling some of those questions of after the resource mobilization, what is our final amount, how is that going to be split between all the various kind of areas, and and as I was trying to highlight, that it isn't just TB, HIV and malaria, there is health system strengthening. I think that health system strengthening component, or RSSH, sort of taking it outside to be much broader than just health systems, but the community systems as well. That is increasingly playing a role, sort of looking at multi-disease platforms. And I think we saw that within COVID-19, is that kind of having a sample transportation network, having community health workers who are aware of infection prevention control, having gene experts that can run COVID tests. These are good for TB but there wasn't enough of them. So when COVID hit, they all went to COVID and TB suffered. But then the flip side of that is I think with the investments that have happened in COVID, particularly I'm going to talk from the Global Fund C19 side, we have been really internally advocating and pushing that this money is used for investments that can support the TB program. So there has been another round of procurement of multi-platform, another round of procurement of digital chest X-rays, which have not come from the TB bucket, but have been added to. So I think, that's thinking about it across the systems and thinking about how to address, many things with one stone, because we don't have the money to do everything we want. And I think also, but Global Fund is demand driven by the country. So the program essentials is a way of highlighting sort of key areas that we think, and it's based on WHO guidance and best practice that countries should be aware of, and but we can't mandate them to put it in, but it's more sort of just raising awareness and making sure, and then the sort of the prioritization exercise happens both within the CCM, and I don't think Yulia's on the call anymore, but I think that's why really making sure that as a TB community we are engaged in those processes. There's a real changes can be made there, and there's been countries, I think South Africa was the last time that got an allocation, and at the country level they decided that they would invest more in the TB program, and that flexibility does exist. So I think we all need to make sure that there's a strong TB voice within the CCM to ensure that where appropriate, changes or sort of priority areas can be adequately addressed. And then a step further back from that is kind of the role of prioritization within an NSP. So an NSP needs to be bold and needs to be really thinking how a country can achieve the NTP targets, but then looking at costing that and then prioritizing it will sort of is helpful for ensuring, and then having those conversations about equity and sort of within those prioritization processes. So it's not just all best bang for your buck or kind of some of the other sort of, well, that population is hard to reach and there's not that many of them, so we'll just ignore them because we were looking at impact. But having that rounded conversation, and I think, and Ernesto might want to add on this, kind of that there is the guidance out there to ensure that. But so I think that prioritization and how we're going to do as much as we can in the most equitable way with the resources we have happens. Everyone has a part to play in it, and there's many areas where we can try and influence it for the better. Thanks.
Thank you, Grania. Any other questions? I'd like you know, my research funders to take a peek at how you guys organize funding, Grania, because there's not that much mention of equity-oriented solutions when it comes to clinical drug trials, you know, funded by our various country funders. It's all separate pots of money for separate things, you know, no integration. So thank you. Any thoughts in general? Just wanted to open it up for the last few minutes. Petra, you have a question or comment, I guess. The new Global Fund framework is very inspiring. It would be great to see new proposals implementing TB programs in this frame. It'll require a true shift in mindset for many programs. Exciting. Thank you for sharing that. And, you know, Petra is part of the TB PPM. She's running that piece. Any other thoughts or comments from the audience before I open it back up to our panelists to share some concluding words? So I think what we've maybe accomplished today is have a bit of that elevated conversation, right? No solutions, just some more transparency in the problems. But also exciting to hear, you know, firstly from Ernesto about the movements that are being made at the WHO Global TB Program, even just by the look and feel of the latest Global TB report, and the activities around equity, human rights, and social protections and disability at that level, which is really nice to see. Really incisive and cutting to hear Uzma's comments about, you know, the practices that have to change on the ground and sort of the auto-colonial pieces as well. And just kind of paying attention to how the sort of subtle and sometimes very explicit, I guess, ways in which colonial tendencies just kind of seep through the work we do. And then moving on to Shea's talk, which was kind of, you know, I had to stop and think for a minute, what's this got to do with equity in the first few slides? And then he gets at it, and I was like, oh wow, just kind of shifting us to think twice about the things the assumptions that we have and hold about decentralized care or fragmented care or specialized care, what have you, and thinking about being really mindful of the gaps that might exist depending on the approach to which we take in making decentralization happen. And how that could fuel inequities, right? That Uzma raised, that even Yulia has raised. And then moving into Yulia's talk on multi-sectoral action and just like the framework that has come up to hold that in place and maybe propel that move forward. But this idea of, yes, TB is not a standalone problem. It's a social, you know, we all know it's a social problem. So it's going to require different sectors coming together to address the determinants and impacts. And ending off, of course, with Grania and you know, where's all this money going to come from? And just really nice to see this push on disaggregating data, so that there is some actually accountability built in when you see that, wait a minute, the rates are so high in this population, or the catastrophic costs are even worse in this particular group of people. And so I think capturing that is a great step in the direction. So I'll just ask again, maybe Ernesto, did you have a few last closing comments, followed by Uzma and Grania?
Thank you, Enrita, and thank you for the 31 people who have stayed with us over the last couple of hours, which to me means is a great success, right? It speaks volumes about the interest. I think there is, this is a big agenda. We cannot pretend to exhaust all the corners, all the areas through this seminar. So I think it's something just to be repeated and expanded, because there are many issues emerging from each of the presentations, right? Very, very rich. And I think that probably for the next union meeting in Paris, we can consider to invite, we can consider to invite speakers from other sectors, and particularly outside the TV community, to prevent we end up with a very much inward looking to our problems. I mean, listening to Granny, and this is not any kind of personal remark to you, but talking about inequalities, the Global Fund is allocating 18% of the cake to tuberculosis. What could be more unequal than this distribution of the funds when we are dealing with a disease, that an epidemic that is driven by inequalities? So this is the big, not elephant, but blue whale in the room, right? And these are the kind of things that the community of TV needs to address. And is the, I insist, is the civil society to speak up, are the member states to speak up? And the solution is not only with the funding of Global Fund or with the policies of WHO. Everybody has to contribute. So thank you very much for having me with you, and really a pleasure and a very enjoyable and learning experience. Over.
Uzma. Thank you, Ernest.
So thank you everyone, and thank you so much, Amrita and Shifty B, and it's been an excellent session and extremely warm to like kind of contribute as well, like, you know, and see if, and talk about things. I feel like one of the themes that comes across is around how to be more inclusive and have community engagement and get people to be empowered to do it. And I think some of this rests on you know, a lot of participation in organizations that I've talked about before, but also the way it's done. I think there needs to be a way of thinking things differently. I mean, when we talk about community engagement, and that's one of the questions that happened earlier, and from a participant from Vietnam, and Mike's point as well, you know, there are language barriers, you know, and how do you, like, you know, so a lot of community engagement has become centralized because everyone speaks in English. So you'll have the South African communities, you know, you'll have from other Western areas and other places, but those who are not really are actively contribute and speak different languages, how to make them participate in it. I think that's an important thing to do, because otherwise you will not be able to have more inclusive, transparent community voices engaged in, you know, influencing national strategic plans or other things as well. So I think that's it's an important aspects to look into, and how we talk about global health and how we want to shift the agenda. So thank you very much.
Thank you, Uzma. Grania.
Yeah, I mean, I think from a global fund side, I think having the pressure, being sort of everyone involved in ensuring that we get, you know, the TB is allocated appropriately in the next round of funding requests, engagement in the CCM processes, and using the program essentials, which has kind of this key equity bit within it to give you evidence to make the fight for more work on addressing inequities in TB would be good. And then I think just we're in the UN HLM is coming up next year, and I think it will be, that's another, going to Ernesto's point of that going outside kind of our small TB world, this is heads of state. And so we also all need to work on getting TB on their agenda and taking it sort of, and making bolder commitments, not just on, you know, numbers of people treated, but addressing addressing the social determinants, addressing some of the key drivers of inequity within that, because then that gives civil society groups and other partners in country sort of something to hold, to use as an advocacy tool to get more, achieve more, and hopefully mobilize additional resources or bring in other partners to help address key areas. Thanks.
Thank you, Grania. I'll move over. Just a reminder, anyone from the audience has a question or comment, please raise your hand. And Jeremiah, followed by Angela and Nora.
Well, I can only say just very, very thought-provoking sentiments shared during the course of today. And to the different levels, we need to look at all these dynamics, not just at international level, but even at local level, the systems that are reproduced. I mean, they need to be confronted and dismantled even at that level. And we just don't need to shy away from that. I mean, sometimes it can be a challenge looking at how the world has moved in the last century or couple of centuries post-colonialism. But indeed, the structures that are sustaining inequity at local level need attention, but also the tensions, the tensions of how to bring people on board, who initiates the conversation, how do they initiate it, what Uzma was just saying, what language they use, what mechanisms are in place, how equitable, inequitable are those mechanisms. Really very interesting conversations, and I certainly look forward to continuing discussions. Over to you, Amrita.
Thank you. Angela?
Thank you for all the great discussion we had this morning. I learned a lot and thought a lot about all these things. And I think it's really interesting that we're around, I mean, I'm looking at the list of attendees. These are names I've heard about from Amrita, Jeremiah, and Nora over the past few years, and names I'm familiar with. But I know that everyone is working in various different contexts, and it's really interesting how these specific topics that were talked about today applies to kind of like what Jeremiah was saying, applies to kind of a global level, but also local, wherever everyone is working and is relevant. So I think, it's a conversation to be continued to have, and hopefully that the conversation can go into more tangible outcomes. I know that Amrita had mentioned, this is just the beginning, and the continued next step is to keep having these conversations and eventually change the way that policies work, and eventually change the way that funding works, and hopefully that can make a positive step. So I'll pass it on to Nora, or actually Petra also has her hand up, but someone can take the floor.
Petra, go ahead. Thanks.
Yeah, I'll turn my camera on, sorry. I have a bad voice, but I just really wanted to thank you all to put this on, because it's not very often that we get the chance to talk about a little bit more of the philosophical side of the equity piece, and the social side is so often forgotten when we get actually to implementing TB. We talk about so many of the patient's needs and immediately go to the tools. So I really, really appreciate Shift TB, the whole group that has put this together to highlight the social aspect and how much TB is a social disease, because that doesn't get enough attention. And one more thing I wanted to say is that anyone who is writing about this, or researchers in this room, thank you so much, because I also feel that is an under highlighted area of TB for many, many years. So again, I really just want to send my appreciations across the virtual channel with a rough voice. So thanks to everyone.
Thank you, Petra.
Thanks, Petra. These are really nice and kind words. I think what we're trying to do at Shift, and I was really happy today with the workshop being an example of it, is to bring out these conversations about the more social sides of TV and explore some of these more complex questions, you know, where you have a lot of theory and underlying research. And I think today's workshop was a nice example of how all these speakers really bravely tackled this very complex, you know, construct of equity and inequities, and brought it across in a way that we could all digest it and follow it, and I think be inspired by it, and hopefully implement some of these things in our respective work. I was struck how, you know, all the speakers also really tackle these really structural determinants and factors that you know, cause inequities, so that we don't shy away from this. And what we'll do at Shift TV is that we'll analyze, you know, what all the things that have been said today, the comments from the audience, and we think about how to move the conversation forward. We have a workshop financed already and planned for next year, where we're just, you know, doing a program for it. But we also think about we will think about other outlets or other little modes of communication, advocacy, or workshops, or so that we can talk about this. So if anybody has an idea of, you know, that comes to mind after this, oh, this is something that Shift TV could take up or could work on, please don't hesitate to contact any of us. We are mainly here to connect those researchers working on the social aspects of TV. So it's a lot of social scientists that we bring together, but we can of course also think about other things, you know, linking up with advocacy or with implementers, or translating some of the insights from social sciences better, etc., etc. So yes, I'm really happy with today's workshop. I think it was a great success, and really, really grateful for the speakers for putting in all this work. These are not easy topics to tackle. And I think, yeah, they all did a wonderful job.
Thank you so much. And thank you to the union. Have a wonderful afternoon or night, wherever you are. Thank you.
Thank you.
Thank you.
Thank you.
Thank you.
Thank you, bye.
And please sign up to our newsletter so that we can stay in contact with you. All of you people interested in equity, please sign up to our newsletter, because we do not have your email addresses.
We've done that, Nora, thanks.
Please complete the satisfaction survey of good feedback from our workshop organizers. And you will be receiving the updates to the recording of today's session.
We cannot hear you, Caroline. We cannot hear you.
Sorry, maybe can you hear me now? I just want to remind our participants to complete the satisfaction survey.
Okay, we hear you now.
Feedback on the work.
We hear you.
And on behalf of the union and the presenters, thank you, everybody. Have a wonderful rest of the day, wherever you may be. Thank you.
Thank you.